Okay, we can get started for tonight. Good evening, everybody. I'd like to welcome everyone to tonight's Journal Club meeting. My name is Dr. Jessica Buttinger, and it's a pleasure to serve as the club advisor moderating tonight's Journal Club. I'm one of the 2025 SMRC officers serving as the PM&R representative, and I was one of the AMSSM members that initiated the development of this Journal Club 3 years ago when I was the Medical Student Interest Group president. I'm currently a PGY2 resident at Mayo Clinic in Rochester, Minnesota, and I'm really excited to be here tonight to hear two amazing presentations. Just to go over the goal of the Journal Club, the goal is to provide a national platform for students and resident members to present an article from the list of the top 120 articles that every sports medicine fellow should be familiar with. Our intent is to make this a fun learning experience and to give medical students and residents mentoring opportunities with other AMSSM members, while also developing skills of reviewing the articles and making PowerPoint presentations. Ultimately, we will have two presentations tonight. The format of the Journal Club is going to be 20 minutes for each journal presentation, and that includes a Q&A session at the end. I'd love for you to enter your questions in the chat function during the Q&A, and I'll read your questions and we'll get them answered by the presenter and the club mentor. So I'll first introduce our first presenter of the night. It's Dr. Savanna Thompson, and her club mentor is Dr. Shawn Kane. Savanna Thompson is currently a PGY2 family medicine resident at Providence St. Joseph Hospital in Eureka, California. Her interest in sports medicine stems from her background in women's collegiate wrestling, and current interests include injury prevention, ringside coverage for combat sports, as well as focusing on ultrasound-guided therapeutic injections for patients living in rural areas. She's also a proud mother of Rowdy, a 10-month-old boy, and she's really looking forward to future involvement in sports. Her presentation article tonight is Acute and Overuse Injuries of the Abdomen and Groin in Athletes. I'd also like to thank Dr. Kane for serving as the club mentor. It's a special opportunity to have Dr. Kane here, as he's one of the primary authors on this article that Dr. Thompson is presenting. Dr. Kane is a professor in the Department of Family Medicine at the University of North Carolina, Chapel Hill. He splits his time between clinic, where he does both primary care and primary care sports medicine, and services as medical director for the Transforming Health and Resilience in Veterans, or the THRIVE program, as well as the Brain and Body Health program. I'll turn it over to Dr. Thompson next to go ahead and start her presentation.
Thank you so much for that introduction. Let me pull up my slides. All right. Good. Okay. So tonight I have just the honor of talking about acute and overuse injuries of the abdomen and groin in athletes. And as mentioned, Dr. Kane is one of the primary authors in this review article that was initially published in March of 2010. And so really the goals for tonight are going to be reviewing the pathophysiology of some pretty common abdominal and pelvic conditions in athletes, and then as well as discussing the primary care sports medicine physician's role in recognizing, treating, and managing these athletes or injuries in athletes. Right? And so first, kind of why we want to talk about this, abdominal injuries are relatively common and comprise almost 5% of all sports-related injuries. And I think what's interesting about this is they can present both acutely and kind of chronically and insidiously over time. And so here, this kind of diagram is just to highlight the fact that with muscle imbalances and maybe improper, incomplete rehab, you can kind of get excessive like loading stress or imbalances that cause inflammation and then contribute to re-injury. And so a lot of times athletes can get stuck in this kind of chronic re-injury and pain cycle. I also just kind of want to frame our whole talk tonight around like just a, I guess, practice question to get in the state of mind. So we have a 25-year-old male who's presenting, a soccer player who presents with gradual onset chronic sharp groin pain. He notices that it's particularly during certain quick changes in direction or kicking. It worsens with activity, but is improving with rest. And he's complaining of tenderness in the lower abdomen near the pubic bone, and it's kind of radiating down into the inner thigh. But on exam, there's no visible bulge in the groin area. And so hopefully by the end of tonight, we're going to be able to answer what we think the diagnosis is and what physical exam findings would support this. And so we'll jump right in to our first topic, ETAP. So this is also known as exercise-related transient abdominal pain, but more commonly a side stitch or side ache. It's pretty common. It's that acute, well-localized pain. It can be found in really any region of the abdomen, but your classic description is going to be that sharp, stabbing, cramping quality. And it's really the repetitive kind of torso movements that seem to predispose a lot of people to this. Several studies have looked at like risk factors or correlation between BMI, sex, age, or even like endurance or training status, but no clear correlations have been found. Again, it can kind of occur in any region of the abdomen, and that's what this figure is highlighting. It is maybe more common on the right side among adult athletes, but in adolescents, specifically 7 to 16-year-old, seems to be more common on the left. And there's several theories of kind of the etiology of this. And the first theory is a diaphragmatic ischemia or spasm, and this seems to be kind of the most popular etiology. Any kind of demanding or exertional activity that's reducing blood flow to the diaphragm, causing ischemia, can cause the pain. But there is some evidence that opposes this theory, and that's specifically that certain activities with a low respiratory demand, such as like horseback riding or even motorcycle riding, can cause similar symptoms. And so maybe the ischemia is not there, but you have that repetitive torso movement. So additional theory is the peritoneal ligament stress. And so evidence for this kind of, we know that certain jolting type activities can cause the similar like ETAP pain. But we also know that there's not really an association with increased BMI, which would also potentially contribute to ligament stress. So maybe that's a little bit evidence against. And a third common theory is the exertional peritonitis. And so the thought behind this is that potentially friction between the parietal perineum and the abdominal wall cavity can cause some discomfort that produces that like classic side ache symptom. Likely, it's really a multifactorial cause, but the common factor between all of these theories really boils down to the phrenic nerve involvement because each of the tissues is innervated. So something's contributing to the phrenic nerve irritation or pain that's causing this ETAP symptom. And diagnosis is really clinical. It's going to be that classic history that I'm getting this pain with exertion and it goes away with rest. And treatment is very conservative. It's focusing just on position changes to kind of relieve that. There's other differential diagnoses, but again, the key takeaway is that if this is resolving with rest, it's likely not a rib fracture or a splenic infarction. Moving on to rectus abdominis injuries. And so we'll just kind of remind ourselves about rectus abdominis muscle and the origin and insertion. And the primary function of this muscle, taking us back to anatomy class, is really going to be flexion of the spine and compression of the abdominal contents. And so when we think about injuries to this muscle, we can think about a strain versus a tear, but either is going to really present with anterior abdominal wall pain. And you know, this could be due to dynamic motion or static motion. And so we think about where the muscle body is inserting. You can have a tear if you have dynamic load that it's exceeding the tensile strength of the muscle, versus like if the core of like the muscle is excessively loaded, as in like a cross check or some type of block in football, you can get those abdominal injuries. And when we talk about the exam findings, it's really going to be pain that's reproduce with provocative maneuvers. So thinking about those sport-specific kind of position that they were in when they started experiencing the pain, as well as having abdominal tenderness on palpation, most commonly below the belly button. A specific physical exam finding is the Carnett sign. And so this is where you can reproduce the pain, having the patient kind of do flexion against resistance. And so here you're palpating the rectus abdominis and asking them to sit up or lift their head, and then reproducing pain. Certain studies are not necessarily indicated, so imaging to rule out other intra-abdominal pathology can be helpful if you aren't convinced by your history or physical. But most of the time, the ultrasound or MRI are really just going to be looking at the abdominal wall itself, whereas a CT would exclude intra-abdominal wall pathology. And so when we think about treatment of the rectus abdominis injuries, really it's going to boil down to a solid rehab program, and kind of the 5 core principles of your rehab program are initially going to be starting with rest, controlling pain, reducing inflammation, and then progressing to strengthening exercises. And we look at isometric strengthening first. And so this is going to be specifically for the rectus abdominis, looking at a plank or a hollow body hold. And then you have your concentric strengthening. So this is your crunch, your bicycles, or your V-ups. And then the eccentric strengthening, so doing your slow, like knees to the elbows, where you're in that flexed core position, and then kind of like slowly letting your knees down. And then the 5th and maybe overlooked kind of principle is really focusing on maintenance and injury prevention, so you're not falling back into that re-injury cycle. And recovery, can range from 3 to 8 weeks, depending on the severity of the strain or the injury. Moving on to groin pain. This article kind of highlights that the 3 most common causes of groin pain are, your sports hernia, your adductor lesions, and then osteitis pubis. And those really comprise most of the injuries. And so we'll kind of focus on those 3 in particular. So looking at osteitis pubis, this is going to be your, presentation of this insidious onset pain, sometimes at the pubic symphysis, but it can radiate into the perineum or even medial thigh. And there was a review article in AFP that actually mentioned that up to 80% of athletes with documented osteitis pubis are actually complaining of adductor pain. So it can definitely be referred pain. But specific activities like kicking, twisting, or sudden acceleration are really going to be aggravating this pain. And it, again, is a clinical diagnosis, so that history is going to be really helpful, that it's exacerbated with these movements. On exam, you may find tenderness to palpation over the pubic symphysis. And in particular for female athletes, it'll be important to exclude that suprapubic tenderness and whether this is a cystitis or other referred pelvic pain. Imaging can show pubic symphysis widening or even sclerosis at the margins if you were to obtain like an X-ray. And treatment is also conservative, so really focusing on inflammation control, rest, avoiding exacerbating maneuvers, and then slowly like moving towards pain-free activity. Some evidence for possible corticosteroid injections into the pubic symphysis have been shown to have more rapid recovery. And then this is just kind of like highlighting where you see all of these muscles like inserting here. And so repetitive stress is going to kind of cause like that pubic symphysis widening specifically with like these kicking motions. And here's just X-ray findings. So you see that widening of the pubic symphysis and potentially even sclerosis at the margins. So similar presentation and sometimes difficult to tease out, but adductor strains can also kind of present in a very similar way. And so you have pain on palpation and pain against adduction with resistance. So having them kind of try and bring their knees together while giving resistance can reproduce the pain. And X-rays can be helpful here to exclude fractures, avulsions, or apophysitis, depending on the age of the patient. And we can use ultrasound for diagnosing a tear, but not necessarily a strain. And so here, teasing out which of the 2 may be causing the pain is potentially less important because treatment really boils down to the same conservative measures. And then athletic hernia. So, our sports hernia or athletic hernia, it's such a big component, but this is that chronic groin pain in athletes that's really been unresponsive to the initial conservative measures. And so this is that exam finding where, they're complaining of that groin pain, but you're not finding any palpable defect. Interestingly here, when they do surgical intervention, there are multiple defects found in kind of the posterior abdominal wall. And so the thought is that this is kind of like that incipient direct inguinal hernia. So it hasn't quite turned into a full hernia yet, but we are seeing some like microperforations or some changes in the posterior abdominal wall. And this is thought to be a diagnosis of exclusion. And so you really want to rule out a lot of other things before you can settle in on this diagnosis among your athletes. But history is going to, show that patient has pain with activity, but is pain-free at rest. And it's kind of been this gradual onset and usually present for over 6 to 8 weeks and hasn't responded to your initial conservative measures. And this is just kind of highlighting the anatomy. So we think about your external inguinal ring, you may have tenderness to palpation there, as well as like pain at the pubic tubercle. And specifically the exam maneuver, you would have them kind of attempt a sit-up with resistance and then reproduce pain at that site. Treatment, interestingly, is actually thought to be surgical because the non-operation treatment has failed to really provide any relief. And so as we would expect, there's open versus laparoscopic approaches, and we know that there's a shorter return to play time with laparoscopic surgery. One thing that I found interesting that this article highlighted was that when athletes are complaining of unilateral pain in one side of the groin or the other, the surgery findings up to quite some time, like up to 40%, I think the article mentioned, actually are on the contralateral side. And then the article also mentioned that we really don't have a good consensus on return to play guidelines following abdominal surgery. It's really provider dependent and can vary quite a lot. And so moving on to talk about true hernias, so ventral, inguinal, and Spigelian hernias. This is really that true defect in the abdominal wall. And so we think about risk factors, including abdominal weakness or even increasing age that are going to predispose someone to having a hernia. We review the anatomy of kind of like our indirect and our direct hernia. And then a lot of treatment or a lot of large studies have really showed that we can kind of wait to pursue surgery unless like pain is uncontrolled, with the exception of a Spigelian hernia. And the thought behind that is they do require pretty prompt surgical treatment because they often are associated with bowel incarceration. So just to bring us back to our kind of question, we have that 25-year-old male soccer player. They're complaining of this gradual onset groin pain exacerbated by kicking and changing movements. And when we performed our exam, we didn't find any visible bulge in the groin area. And so, our most likely diagnosis is definitely an athletic hernia, and the physical exam findings that can help support this are going to be that pain with a resisted hip sit-up right there at the pubic tubercle. So the main takeaways of this article really focus on the fact that abdominal wall injuries and groin pain are really common injuries among athletes, but can be very challenging, both for the athlete because they can be chronic and really impact their overall like athletic career and future goals, and challenging for the clinician because there's such overlap between a lot of these injuries, and most of them are really based on that like clinical exam, the history, and the physical. And the takeaway of that is our history and our exam really are the cornerstone of an accurate assessment. One of the limitations of this article highlighted just the need for more standardized regimens for post-surgical rehabilitation, specifically looking at like abdominal surgery. And then a takeaway for kind of us as sports medicine physicians, it's really important that we have a solid knowledge of the underlying anatomy and that we're prioritizing excluding intra-abdominal pathology before we're moving on to these other diagnoses that really require a more conservative treatment approach. And then, the other big component of this is kind of the sports psychology role and how we oftentimes have to mentally prepare the athlete for the time and effort that it's going to take to really correct the underlying muscle imbalances that may be contributing to injury and re-injury. And then I just wanted to make a little note that since 2010, when this article was published, there have been some other case reports that have highlighted potentially other treatment options. And we are moving into this whole era of orthobiologics and PRP. And so there have been several case reports that really support the use of PRP for osteitis pubis and adductor strains in particular. And then there's several orthobiologics that are advertised for this, as well as prolotherapy. So that's another option out there. Still waiting for more conclusive evidence on like the overall efficacy of these options, but there at least is more, I guess, research being dedicated towards their treatment options. And then I was looking to find some more recent review articles talking about post kind of abdominal surgery rehab protocol, but still it's kind of highlighting the need that we don't have a standardized return to play protocol. But I just wanted to give a special thanks to Dr. Kane, who's been a wonderful mentor as we reviewed this article together. And then these are my sources.
Awesome. Thank you so much, Dr. Thompson. And I wanted to kind of open up the floor for Dr. Kane to maybe share some thoughts before we dive into some of the Q&A questions.
Yeah, thanks for having me, and thanks for Savanna for doing a good job. It was interesting when this was brought up to me because it kind of obviously dusted off some memories and stuff. And yeah, this article was written, in the dark ages of 2010 at this point. And I think some of it still holds true, in terms of rehab and, it just takes time. Obviously, as Savanna highlighted there at the end, nowadays with orthobiologics or things like prolotherapy, people are trying a lot of different things. And I think a lot of these conditions, the challenges with them is these are kind of chronic nagging things that can really impair someone's performance. Obviously, if they're an elite level athlete, it's a big deal. Sports hernias and stuff, you hear a lot of them in, NHL players or soccer players. And even if you're just kind of a, weekend warrior, these can be chronic and nagging. And it's, so using things like, or the evolution of things like Prolo and PRP, et cetera, are all worth trying. Whether they work or not is another aspect, just because they can take time and stuff. But yeah, it's, again, physical exam is important, considering, how to work it up, who to refer to. I mean, when I remember when we first wrote this article, like getting surgeons interested in the idea of operating on an athletic hernia was a little bit of a challenge, as it was somewhat of a, I don't know, I would say no man's land, but whether it was real or not, I think now it's a lot more accepted. People are a lot more aggressive in fixing them. We have a hernia kind of specialist here at Chapel Hill, and so she's pretty aggressive with the couple I've had. We kind of ultrasound them, and she's really even more so just on clinical diagnosis, doesn't necessarily do a lot more imaging. I'll usually have people go get a formal ultrasound, and but she's like, I think pretty aggressive as it's come along now. Like Savanna said, that surgery is kind of a better treatment. So an interesting idea. And I think some of the tenets are the same for the treatment in terms of the rehab, as Savanna laid out for a lot of these. But then obviously nowadays, maybe trying some of those other orthobiologic things as well as rehab are important. So appreciated, her choosing it, and really enjoyed, working with her and being part of this. I think it's a great idea. So open for any questions.
Looks like looking through the chat. So Anton pointed out in the chat that there's actually a very helpful 2015 Doha consensus statement, and it really nicely classifies groin pain in athletes into subgroups and has found it very helpful. So I think that's shared in the chat for anybody interested. And then there's a question regarding getting an MRI to diagnose a sports hernia versus, ultrasound and CT.
Yeah, no, I think that's a really great question. I will go back here. So I think what I was reading in the article is that the utility of actually getting additional imaging, like an MRI, is oftentimes not very helpful. And I think I'm trying to find the slide. Maybe I didn't include it here, but great question. From the takeaway from the article was actually showing that oftentimes additional imaging really is not likely to be much helpful. It's kind of just the history, they haven't gotten better. And then on surgical exploration, you can kind of see those microperforations, but we aren't seeing like a true defect or a true like herniation through the abdominal wall that the MRI would point at. Unless Dr. Kane, you have additional thoughts.
No, I would agree. Like I will admit, I think back, back around the time of this article was written, I can remember had a case or two, and we did MRI things. I was in the Army at the time, so we could MRI anything because it had no cost, et cetera. So it was a little bit easier. But to try to find pathology to maybe convince the surgeons to, intervene. What Savanna's saying, and I agree with it. And now, like I said, I kind of even do less imaging, and it's very much history, physical exam focused. Not saying an MRI is not a bad idea. I just, you could probably, I think, get it taken care of with an ultrasound or physical exam. But it's probably not a bad idea, or it wouldn't be a bad idea. I don't know if it's needed, but
Awesome. Thank you for those thoughtful responses. In the interest of time, I'll move to the second article now. Okay, so for our second presentation tonight, I'm pleased to introduce Dr. Tiffany Ruan and her club mentor, Dr. Katherine Wainwright. Dr. Tiffany Ruan is a first-year resident in the family medicine residency at Rush University. Her interest in sports medicine is influenced by her personal experience with Ehlers-Danlos syndrome and previous surgeries on her hip and shoulder. She's deeply passionate about assisting others in restoring their physical function and mobility. Outside of work, Tiffany enjoys running marathons, attending Broadway shows and symphonies, and traveling to various countries. Her presentation tonight is on the article Exercise-Induced Laryngeal Obstruction, a common and overlooked cause of exertional breathlessness. I'd like to thank Dr. Katherine Wainwright for serving as the club mentor for tonight. She is a family medicine trained sports medicine fellow at the University of Washington. She presented an article at an AMSSM Journal Club last year, and she's really excited to help Dr. Ruan now do the same. Her interests in sports medicine include tendinopathy, sports cardiology, and peripartum exercise. On a personal note, Dr. Katherine Wainwright and I actually went to Duke together, so it's a small world. She was on the lacrosse team and I was on the field hockey team. So I love how, going into sports medicine field with your friends, it's amazing in a small world. So Tiffany, Rowan, you can go ahead and kick us off for the second article.
So hi, everyone. My name is Tiffany Ruan. I am a PGY1 at Rush, and my club mentor was Dr. Katherine Wainwright, and she's at UW Washington. And today I'll be presenting on exercise-induced laryngeal obstruction, a common and overlooked cause of exertional breathlessness. I want to emphasize also that this is the only paper that I used for context in this presentation, and that other papers also exist. I do not have any disclosures. So just to give a brief introduction on EILO, or exercise-induced laryngeal obstruction, prevalence most often is seen in adolescents. When it comes to the general population, we're talking about 5.7 to 7.6%. And then when it comes to athletes with respiratory symptoms, this can increase to 35 to 70%, sometimes with asthma, sometimes those without asthma, and then this can include sometimes be misdiagnosed and treated as asthma despite equivocal findings. This is important because EILO is very common in athletes, and it impacts exercise performance and quality of life. Tends to be confused with and inappropriately diagnosed and treated as a lower airway dysfunction, such as exercise-induced bronchoconstriction, also known as EIB, and asthma. And then when we're looking at common presentations, we usually see this among young athletic females, although it does also affect males, those that are usually under the age of 20 years old, symptoms of shortness of breath. They also have increased respiratory effort, throat discomfort, chest tightness, and wheezing that occurs during exercise. When we look at differential diagnosis, we have to rule out the red flag symptoms. So any respiratory or cardiac signs and symptoms that include chest pain, palpitations, cardiac murmurs. Another commonly used diagnosis or phrase that's used for this type of presentation is exertional vocal cord dysfunction. However, we're talking about narrowing that most frequently occurs at a level above the vocal cords, and this includes the supraglottic structures. So exercise-induced laryngeal obstruction is a more appropriate descriptor. Symptom onset usually occurs during strenuous exercise, and then it settles rapidly within about 5 minutes of exercise cessation. This is a good table that was also shown in the article, but it differentiates between EILO and EIB. So when we're talking about EILO, it's usually fast onset that peaks during exercise, shorter regression duration, and then we'll hear inspiratory wheezing during these episodes, and beta agonists are essentially ineffective when it comes to treatment of EILO. When it comes to EIB, it's a slower onset following exercise, longer regression duration. We'll hear an expiratory wheezing during the episodes, and beta agonists can be effective in treating exercise-induced bronchoconstrictions. Symptoms and precipitating factors can actually make it difficult to distinguish between the two diagnoses because they are so similar. When we're looking at diagnostic assessment, the gold standard test is called the Continuous Laryngoscopy Exercise, or CLE. It's a real-time evaluation of laryngeal movement during exercise. And how it's done is achieved by placing and securing a flexible laryngoscope into the nasopharynx. And this permits an uninterrupted assessment of the laryngeal function during exercise, thus characterizing any propensity to closure. And so this is a picture or imaging of a CLE in someone's larynx. And in normal breathing, vocal cords usually fully abduct to increase the surface area and maximize air coming in and out of the lungs. When we're talking about abnormal flow, there's an abnormal degree of adduction of the supraglottic structures and or inappropriate closure of the glottis. When this closure generates then turbulent flow and increases resistance, which in turn promotes laryngeal closure, resulting in dyspnea and then the inspiratory stridor that we hear. The CLE test allows patients to visualize where their symptoms are arising because it's shown on a screen while they're exercising, and this can also inform treatment. So I wanted to show a quick video of how CLE is performed because a lot of people, especially primary care doctors, sports med doctors, are unaware of how CLEs are performed. So this video is great to show.
The first thing you need is to ask for a proper asthma test. After you have done a proper asthma test and you have seen that asthma is not causing the problem, you can say to the GP, general practitioner, that you need to be examined for a laryngeal problem during exercise. It doesn't help looking at the larynx at rest because then it will be normal. And so you actually need a test for the larynx during exercise. And to do this, we do a continuous laryngoscopy during exercise test with a laryngoscopy through a mask and the nose. You get a good view of the larynx, and then the patient are running on a treadmill or are biking on a bike. I think it's very important that the people see the respiratory system as one thing from the top and to the bottom, and don't see one part from the other, because you need to test the whole system. If you are figuring out what is causing the breathing problem for the patient, then you need to look both at the lungs and the larynx to solve it. The treatment option we have for EILO is divided into conservative treatment and surgical treatment. And for conservative treatment, we have guided breathing techniques with biofeedback, where we ask the patient to look at the screen, to look at their larynx, while we are explaining how to breathe more correct. And for patients who need more treatment, we have IMT, inspiratory muscle training, which is a device where people are breathing against a resistance. And this helps coordinate the larynx and open it. You get more strength and you get more control. Open. And we also have speech therapy for people who needs more one-to-one treatment and need more time to get control of this abdominal breathing and opening of the larynx. You have a glottic collapse or you have a supraglottic collapse. You can't do surgery on the glottic collapse. But if it's mainly supraglottic collapse that causes your problem, you can do a laser surgery procedure on that. And we're cutting with a laser the supraglottic area that are collapsing too much to open the space. We cannot touch the vocal cord, the glottic area. That's very important because then you're ruining the voice. But it's very easy and a small procedure actually, but it's with full anesthetic.
So the next video I wanted to show is the testing for exercise-induced bronchoconstriction. This is because EILO is commonly confused with EIB, so just showing the different types of diagnostic assessments that are typically used.
The test we're about to perform is an EVH test, which stands for eucapnic voluntary hypnea. You're hyperventilating on a cold, dry gas, but we're maintaining the carbon dioxide levels when you breathe out. And we do that by having you breathe a gas that has a high carbon dioxide content, much higher than normal air, but the same oxygen content. We're going to measure your baseline lung function, and then we're going to try and provoke a constriction response by having you breathe that cold, dry air for 6 minutes. And then after that, we're going to test your lung function again and see if there's been a difference. And put that on your nose. So if you can just blow into this whenever you're ready. Let's go, 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 keep going.
Using the results of the baseline test, a calculation is done to find 85% of the maximal voluntary ventilation, and this will be her target when she watches the readout.
Imagine a really intense running session. Okay, this is the volume of air that you'll be breathing.
She now has to breathe the cold, dry gas for 6 minutes, and even so, she has to try to stay at 85%.
That's it, you can see it picking up, that's where you want it, maintaining that green zone. You've got it, Nick, come on, push, 3, 3, 3, 3, 3. Five, 4, 3, 2, 1. How are you feeling? Hard work?
Then her lung function is tested again to give the final result.
Well, keep going, right up.
So when it comes to management of EILO, first we want to discuss with the patient the nature of the problem that they're being affected by, and for clinicians to consider and highlight the fact that providing there's not a diagnosis of another coexisting exercise-induced bronchoconstriction, that medication use can be rationalized. Time is also spent addressing and minimizing the effect of any laryngeal irritants and discussing regarding strategies to improve laryngeal hygiene. So avoiding smoking, regular fluid intake, and avoiding dietary caffeine. After that, we can make a diagnosis. So if still symptomatic with beta agonist, which is the treatment for exercise-induced bronchoconstriction, the official diagnosis of EILO can be made with continuous laryngoscopy exercise as the diagnostic assessment to visualize the glottic and supraglottic structures. Treatment, as talked about in the video, physiotherapy and speech language therapy are currently forming the basis of treatment. And this utilizes breathing control techniques to improve laryngeal abduction during exercise. Basic strategies also include focusing on nasal breathing to increase the humidification of air that comes into your lungs, inspiratory muscle training or IMT, and overall promotion of diaphragmatic predominant breathing patterns. If refractory to these treatments, then individuals with severe EILO can be treated with laser surgery. So it's called a laser epiglotoplasty. It involves surgical debulking of the redundant tissues, such as the prominent cuneiform tubercles and the aryepiglottic folds that then create the obstruction of the laryngeal inlet. So in terms of prognosis, this is a self-limiting disease. It's responsive to speech and language therapy. And some of the pearls is it can be missed or delayed, the diagnosis of EILO. This is mainly due to receiving an alternative diagnosis like asthma that is more common than EILO, and also due to a lack of awareness about this condition in the community. The delay or inappropriate diagnosis results in patients receiving extensive workups and unnecessary medications. This also highlights the need to increase awareness about EILO in the community, especially among primary care providers, school nurses, and sports coaches. Successful management of EILO requires an interprofessional team approach. So pulmonologists are usually first-line providers. Understanding the main difference between EILO and other differential diagnoses is critical, especially when it comes to asthma. It's also important for pulmonologists to rule out other conditions. Another important key player are otolaryngologists or ENT surgeons. They have a central role when it comes to evaluation of the upper airway structures. Also, in refractory cases, they will be the ones performing the surgical management. Speech and language pathologists also have a crucial role, and they help with preventing recurrent symptoms with teaching the patient how to breathe. Psychologists can also assist in behavioral therapy and biofeedback. And then family clinicians, this includes PCPs, NPs, PAs, can help monitor and assess long-term results after release from active therapy. They also can be the first person to encounter the patient and initiate a referral for more specialized interventions. So after reading this article, I was interested in learning more about the speech therapy and what that really entailed, speech and language therapy. So some of the maneuvers that these articles have found to be effective when it comes to treating people with EILO, one maneuver is called the sniffing maneuver, and it's a fast inspiration through the nose that's applied to make the larynx open as a reflex. Another maneuver is called the Carlson's maneuver, where the patient inhales through closed teeth with extended corners of the mouth, which is a technique meant to slow down airflow during inspiration, and it has been shown to have a positive effect on laryngeal patency. Another maneuver called the yawning maneuver focuses on stretching and widening the larynx. Dew breathing maneuver involves inhaling without changing the position of your mouth or articulators. And then the last type of maneuver is called the semi-occluded vocal tract voice training and therapy maneuver. And this is also commonly used in people that do voice or singing, and get voice training. It's a method of voice therapy that uses exercises which partially block the vocal tract, like using a straw or slightly pursed lips to improve the vocal quality by creating back pressure and reducing tension on the vocal cords. And these are my resources. Questions?
Awesome. Thank you so much for the presentation. I'll open up the floor for Dr. Wainwright if you wanted to make any comments. Other than that, then we'll go into the Q&A.
Yeah, great job, Tiffany. I think this article does a good job of just kind of bringing to mind that exercise-induced laryngeal obstruction and often called, as she mentioned, exercise-induced vocal cord dysfunction is probably more common than we are recognizing. And so anyone with exercise-induced bronchoconstriction or asthma who is not getting better as you would expect with those treatments or hasn't actually had the full workup to really clarify that diagnosis kind of merits us thinking about this and considering this workup as well. And then just one kind of clinical pearl to add is the poor man's speech therapy in folks who are having kind of more mild symptoms as they're out on the practice field. We'll often recommend that they start singing their favorite song as they're practicing, because as she mentioned in some of those speech therapy techniques, singing really kind of opens the vocal cords and the supraglottic structures, and so kind of resets their ability to abduct all of those structures so that they can breathe appropriately.
All right. I'm not seeing any additional questions right now. So I'd like to thank both of our presentations and presenters tonight. You guys did a wonderful job. So both Dr. Thompson and Dr. Rowan. And also a huge thank you to our moderators tonight, Dr. Kane and Dr. Wainwright. You did a fantastic job and a great collaboration and mentorship to these amazing residents. A couple of extra, let's see. It was also a pleasure to be able to moderate and listen to your wonderful presentations. In terms of the next AMSSM Journal Club to be on the lookout for, it'll be Thursday, February 20th from 8 p.m. Eastern time. So we'd love to see you there. And this officially concludes tonight's meeting. Thanks so much for joining us.